Good morning, everyone. I will just slowly start because we do have a schedule, as always, on a conference. My name is Lea Mertens. I'm also welcoming you here on the conference, and I'm very happy to announce our next speaker, which is Professor Albert Garcia-Romeu, and he will talk about the directions for psychedelic therapies in neurodegenerative and chronic illnesses. He's an assistant professor at the Johns Hopkins University and a founding member of the Center for Psychedelic and Consciousness Research, so has been in the field for long, and I'm very happy to and excited to hear your talk.
Great, thank you so much. Hey, good morning. Thank you all for having me here. It's nice to be in Berlin. I've never been here before. First thing you notice is I kind of switched the title of my talk. It's been about, neurodegenerative and chronic illness, but that sounded much more theoretical than this is. This is actually going to be on specific conditions and 2 clinical trials that we're running, which are with patients with Alzheimer's disease and also chronic Lyme disease. So I'll go ahead and start. Some disclosures: I'm a paid advisor to companies, and I've also received money to do research from companies and also the government and also philanthropy. But I think just to give you a background here, the state of the science with psilocybin is such that we have now multiple studies that are converging on the evidence for antidepressant effects, rapid, robust antidepressant effects of a single dose of psilocybin. There's even a paper just published yesterday to add to what I'm about to show you. We also have multiple studies showing reductions in anxiety, depressed mood, and also quality of life enhancement in patients with serious illness like cancer. And so this is also an area that's converging pretty nicely in the clinical research literature. And finally, there's a lot of nice work that's coming, and we're going to publish something soon with cigarette smokers, but in treatment of substance use disorders. And it's also looking quite promising. So this is where we're at with the state of the science with psilocybin specifically. But then, when you're stepping back, then it makes me think, what's next? What else are we going to look at here? But just to, again, give you some of that background, antidepressant effects. This is from a small study at Hopkins, a larger study at Imperial College, another nice size study from here in Zurich nearby, and of course, the largest study to date, 233 patients, 1 dose psilocybin, sustained antidepressant effects. And again, with the serious illness population, specifically in folks with cancer, we've seen that just 1 high dose psilocybin can lead to sustained anxiolytic and antidepressant response, as well as improvements in quality of life. And again, this has been replicated in multiple study samples now. So one of the areas of interest in terms of clinical development, at least for me and some of my colleagues, has been, there's a very large number of people that are struggling with dementia, Alzheimer's disease and related dementias. That's about 55 million worldwide right now. It'll be about 80 million at 2030 and closer to 140 million when we get to 2050. So that's a lot of people, obviously. We also have had over 240 failed drug candidates in the pipeline over the last 20 or so years. Lots of different types of drugs have been tested in these conditions. Most of them don't do very much. There has been some recent advances with these antibody medicines, but I would say that's still a work in progress. But when you look at folks with mild cognitive impairment, which is often prodromal for Alzheimer's disease, you see that they have a very high rate of prevalence of comorbid conditions, including neuropsychiatric symptoms like apathy and depressed mood. And of course, this is something that adversely impacts their quality of life as well as their family and caregivers, the people that care for them. And just to give you but actually a good example of what that can look like in real practice, that when you have the first 3 months after diagnosis of dementia, you see roughly double in the risk of suicide. So obviously this is a really distressing diagnosis to get. There are mood-related symptoms that come along with it very often. And when you look at the animal literature of psychedelics, there's really a fascinating thread. And we did a review on this a little bit, but there's memory-enhancing properties of these drugs when you use them in animal models, and that's true in rabbits, in primates, and also in rodents. They enhance associative learning, Pavlovian conditioning, lots of different types of memory consolidation. And of course, there's been all this recent work with structural and functional neuroplasticity that the drugs can entail, specifically these serotonin 2A agonist drugs like psilocybin. And so, the ramifications are that there could be some positive cognitive enhancing effects of these drugs as well. And this is just an example of some really nice animal literature that's been published recently, showing increased spine density in the prefrontal cortex of mice up to 1 month after 1 dose of psilocybin in these animals. So that's a really important area for executive function and cognition. So again, the data suggests maybe this is something to look at in neurodegenerative conditions. So with colleagues at the Johns Hopkins Memory and Alzheimer's Treatment Center, Dr. Paul Rosenberg and others, we're doing a small open-label trial in 20 treatment-seeking patients with depressed mood and either an MCI or Alzheimer's diagnosis. I designed this protocol based on some of my clinical experience working with participants in other studies, but we're basically starting with a low-dose 15 milligram session in the 4th week, and if they tolerate that well, we move forward to a 25 milligrams dose, which is being used most commonly in many of these antidepressant studies. And then we integrate for a few weeks, and then we do follow-ups 1, 3, and 6 months after the last high-dose session. You can take a look at the design here. It's going to be very similar to what I show you in a few minutes for the other study, because I designed both of those studies. We're looking at depression and quality of life as primary outcomes here, but also looking at anxiety, cognition, caregiver quality of life as exploratory aims. And this is just to give you an idea of what we're looking at, things like the different endpoints and when we're taking them. So right now, we're just about halfway through the study. We have 8 people whose data I'm going to show you today. So obviously, this is very preliminary. We don't have a lot of statistical power. But it's 5 women and 3 men. They're a mean age of 70. We're looking at a primary outcome measure, the Cornell scale for depression dementia. This is often thought of as a gold standard for depression in dementia patients specifically because it does something that is not often done in other types of depression measures, which are mostly self-report or clinical interview. This gets data not just from the patient, but also from their caregiver, somebody that's close to them who can also give some observation of what their mood state has been like. We look at different subscales here, including mood signs, behavioral disturbances, physical and cyclic functions, et cetera. So just to go ahead and show you the data, this is a Cornell scale for depression and dementia on the left. This is a Beck Depression Inventory on the right. And I'll go ahead and keep showing you some more data here, and then I'll explain what we're finding with statistics in a moment. This is participant and caregiver quality of life measures. And this is a Hopkins verbal learning total recall data. And so this is a very crude measure of memory function. And if you just kind of eyeball it, you can see some people seem to be getting better a month afterwards. Some people seem to be getting worse, which is actually what you would expect in a dementia diagnosed patient. So it's kind of curious, what does this all look like when you kind of jump into the stats? And again, so far, very preliminary. However, we have a pretty nice signal of antidepressant effects looking at the Cornell scale for depression and dementia, including significant reductions 1 week and 1 month after the final psilocybin session. But what's kind of weird is not all the data converge there because the Beck Depression Inventory does not show you any sort of improvement. Quality of life for caregiver and for the participant are not showing any signs of improvement. And so the data are kind of mixed. And again, we're still enrolling people, collecting more data. But one of our measures is showing improvement and some of them, another measure is not, especially in terms of depression. And so it kind of wonders, it kind of makes you wonder, why is that? Well, as I mentioned, some of these, specifically the Cornell scale for depression dementia is getting data from the participant and their caregiver. What struck me working with this population is that you can ask somebody how you've been doing, how's your mood been? And they'll say, I think I've been feeling pretty well. And then the spouse or caregiver will say, they've been crying every day for the last month. And so the memory impairment makes it really hard to use their self-report reliably, which is something new that we're contending with in this field. In terms of what are the ramifications of this, one of the things that we found in a few studies is that the more mystical type qualities of a participant's experience, the more reductions they have in anxiety, depression, or things like smoking craving. So the subjective effects of the drug, not always, but often seem to be correlated with clinical outcomes. And what does that look like? Well, when we asked participants from our smoking study, what was most memorable to you 6 months after their session, they give us these kind of cogent responses of what they remember. Feelings of oneness with the universe, the awareness that all is one. Obviously, there's a lot of convergence there as well. But these folks don't really have much memory for these experiences. And so, do the subjective effects matter? Maybe one of the reasons we're not seeing some of these robust antidepressant effects as much as we have seen in other populations is related to the fact that people can't remember the subjective effects of the drug experience and can't really fruitfully integrate them. This is obviously speculative, but it's an interesting thing to think about. Most of these participants do not remember their session at all. So although the treatment effect is still inconclusive, we're going to collect more data, finish the study. I wonder if maybe microdosing might be better and more easily tolerated in this population. And I just want to end here with a note of caution, which is, with folks who are older and vulnerable populations in general, people with cognitive impairments and such, you really need to be extra careful. And so we take special measures to consent them properly, including consenting them with the family or caregiver. And there's, the ethical ramifications of memory loss, including the lack of memory for the experience, because people will come back and say, I don't remember what happened yesterday, but I feel great. And in that session, that's something that a person actually said to me who's in one of the sessions that we ran for her. But obviously in that context, there's a lot of ethical challenges. Thankfully, I was able to show her video. Her husband was there. Everything was fine. But you can imagine if there was bad actors involved, it could be not a good thing. And the other thing is, if these people get benefits, and this is something I struggle with lots of our research, what happens when you send them home after a trial and say, this seemed to help, maybe for a month or 3 months, but now we can't give you any more, sorry. So that's kind of tough. So switching gears here, I'm going to talk about post-treatment Lyme disease, often talked about as chronic Lyme or long-haul Lyme. Lyme disease is a vector-borne illness. I'm working with the actual Lyme expert. I'm not one. His name is Dr. John Alcott, and they have a Lyme disease research center at Hopkins. And between 5 and 15% of folks who get Lyme disease develop persistent chronic symptoms afterwards. And these really impact quality of life adversely. And this includes things like fatigue, pain, sleep disturbance, depressed mood, and memory impairment. And in terms of what's happening at the pathophysiological level, we don't really understand this illness. Most people get better when you give them antibiotics. Some people continue to have these symptoms. Why? We don't know. How it works, we don't know. Interesting study that John Alcott and Jennifer Coughlin published using PET imaging, looking at chronic Lyme patients and healthy controls, showed a very nice, well, not very nice, but very strong signal of brain inflammation in these patients with the chronic Lyme. And of course, we do know that there's these anti-inflammatory effects of psychedelics, including psilocybin. So we're doing a very similar study design with these same patients, post-treatment Lyme disease, 20 folks who are coming in for 8-week study treatment, 15 milligrams in week 4, 25 milligrams if they tolerate the first dose well in week 6, a couple weeks of integration and follow-up, looking at their Lyme symptoms, depression, fatigue, pain, and sleep disturbance. Again, here's just a kind of snapshot of what we're looking at. And to cut to the chase here, this is what they call the general symptom questionnaire, which John Alcott helped develop with other Lyme disease colleagues. And you're seeing, on average, there's a statistically significant reduction. This is in 10 participants so far. We've dosed 12, but I've got data for 10 up here. Statistically significant reductions from after the first dose to after the second dose to the end of the treatment period. But what's curious is that we see this specific reduction on 2 subscales. There's one that's called pain and fatigue, which you see on the left, and then there's another called neuropsychiatric symptoms, that's on the right. These 2 are showing statistically significant reductions after psilocybin. There's also 2 other types of subscales here, viral symptoms and neurologic symptoms. These are not showing any improvement. So it seems like there's very specific qualities of psilocybin that are improving the patient symptom burden. And of course, quality of life is also showing significant improvement because of these improvements in symptoms. So again, these are very preliminary data, but we are seeing already statistically significant results. And I would have to say our findings are very positive here. And I wouldn't normally include this, but a participant emailed me this while I was on the plane from Baltimore to Berlin and said, this is from the period before my psilocybin session and the last 4 weeks, which was a month ago. This is from the period after my psilocybin sessions. Basically, my average step count doubled. And she said it's because I'm feeling much better, I'm sleeping much better. We are tracking physiological data using Oura rings, so it's gonna be interesting to look at this on average, but got this in the email, I thought it was pretty cool. So to wrap up, since I'm up here, I'm gonna go ahead and talk a little bit about things that are also on my mind about the field, namely the hype machine around the work that we're doing. When you see these types of headlines in the news, unfortunately, can be a little bit misleading, and certainly to lay audience and people who may not have same training in critical thinking that is often something that you get in graduate school. And so it leads to stories like this. Can microdosing mushrooms take the edge off a first date? This is something that I call, this is the actual story, I didn't make that up. It's in the media. And at least it's something I call the Disneyfication of psychedelics, but basically, this is a term I stole from a sociologist named Kehoe, this Disneyfication term. Stripping a real event of its original character, representing a sanitized format, dumbing it down, making it more pleasant, easily grasped. And so when we do that for people, I think, or when the media is doing this, I think it's gonna be problematic because if you're a clinician, your patients are gonna show up with very unrealistic expectations. And even if you're a scientist and you're talking to other scientists, they may not understand what exactly we're finding. And so this leads to also problems around the commodification and psychedelics TM, something I stole from my friend Elias Stockwar. But there's really gonna be, I think, challenges that we need to pay attention to in terms of maintaining quality control at scale when we're doing these types of therapies. What are the ethics of commodifying altered states of consciousness, spiritual and transcendent experiences? And of course, turning unpatentable, naturally occurring products that have long been criminalized into for-profit enterprise. And so I love this quote from Burroughs, what does the money machine eat? It eats youth, spontaneity, life, beauty, and above all, it eats creativity, it eats quality and shits quantity. So we need to be careful not to become that. So to close, thank you all for your attention. Thank you so much to the organizers for having me here. My email is up there in case anybody has questions. And obviously, thanks to our team and all our participants.
Thank you for this really, really interesting talk and also for the ethical warnings that were in there. I find very important. Are there any questions? Okay, quite a few. Maybe I will start in front.
Hi, thank you very much for this talk. What got me wondering was when you said that those patients couldn't recall the session afterwards. Have you tried prompting them, for example, with the music that you used in the session?
Yeah. Well, so I've done this with lots and lots of people. Most of them have not had dementias, but almost never have I had somebody come back and say, I don't remember the experience, or at least that, often there's periods that they may not recall or be able to express. But with the dementia patients, like I said, it's very pronounced. I don't remember what happened. I don't have any real recollection. And even if the ones who have less seeming memory and cognitive impairment, we have a playlist, obviously, we replay the music with them. We let them bring in some of their own music that either they or their caregiver bring specifically, and it doesn't really help, jog memory. Like I said, for the one lady in particular who I quoted, I don't remember what happened yesterday, I feel great. I mean, I brought her to the computer, I sat her down and I showed her a video. We have an 8-hour video of her laying on the couch, basically, and said, well, this is what happened. This is basically, you were here with us all day. You got up to go to the bathroom a few times, but that's pretty much what happened. And even with that level of prompting, there's not a lot there. So it's kind of interesting why that might be the case. Again, clinical ramifications of that.
Thank you. So I work as a neuropsychologist at a head injury clinic in the Netherlands. And as you probably know, there's also a lot of chronic psychological distress following brain injury, all these functional impairments, cognitive deficits. Do you see potential in those areas? And if so, are there different considerations to make, ethical, research-wise? Do you have any thoughts on that particular area?
Yeah, I mean, we've thought about it. Matt Johnson and I have, gone to talk, and, we've brought our colleagues who work in this area as well to talk about working with folks with traumatic brain injuries with psychedelics. There seems to be a lot of interest, in particular from the athletic community, and I'm actually have a grad student here from UVic, Bailey Vanderswijk. I don't know if she's here right now, but she's working on some work on that area as well. And, people are interested, but right now everything we have is anecdotal. So, I mean, that would be great to do a clinical trial. I think, and, looking at both microdosing regimens and high dose experiences to see, what could happen there in terms of potentially both reducing some of that psychological distress, but also maybe helping with some of these other functions. Again, anecdotally, like our chronic Lyme folks have been really talking about many of them improvements in sleep quality. And I mean, just that alone can lead to lots of robust positive changes in mental health status, I would imagine. So, we'll have to see what happens if we did an actual clinical trial, I think. Yeah.
Okay, there are some more questions. Are there also questions from the online audience? No, okay. Then we stick to the room, also fine. Maybe.
Hey, great talk. I was wondering, because you're looking at, I guess, both Alzheimer's and chronic Lyme have a pretty substantial, not just psychological, but physiological inflammatory component. And as far as I understand, there's some research going on in the United States looking at psychedelics as anti-inflammatories. Are you looking at inflammatory markers in these studies, and or are you seeing reductions in inflammation, like that brain scan you saw that you had at the beginning of the slide?
So we're not doing any brain scans. These are preliminary studies. Really, we want to understand, like, is it okay, feasible, and safe for us to give these populations high-dose psilocybin? And so far, it looks good. We haven't had any problems. But yeah, we're doing a lot of biomarker work, and that's not my area, but we've designed that in to look at things like inflammatory cytokines, C-reactive protein, working with microbiome researchers and looking at stool samples before and after psilocybin exposure in the gut microbiome. So lots of different stuff that we're looking at, and we're going to try to correlate that back to symptom changes that we see. However, because these are not controlled studies, we're going to not really be able to have very strong conclusions. But it might give us a good direction or pointer for when we do studies in the future that are controlled, if this seems to be helpful, then what we should be looking at. And I think those, that's a really good area to look at, those inflammatory markers for sure.
Thanks. Very interesting topic to work with dementia patients. And obviously, I don't have a clinical experience, but just a personal experience taking care of my grandma in the very late stages of dementia. I think you pointed out also in your lecture that the standard just depression parameters maybe not the right measurement of success in this treatment, because depression is just kind of one of the side effects, but there's like just quality of life, because people are not remembering anything, and at some point they cannot talk anymore. And can this treatment give them something else, some kind of meaning or something interesting in their life where they cannot do many other things? So I don't know if you looked at what kind of other parameters you can measure, and maybe also look at art therapy as a complementary part.
Yeah, I wish I would have thought about that more earlier on, because I think that it's really would be a fruitful additive component to these types of therapies, particularly in patients with dementias. But it sort of emerged naturalistically, particularly one lady, again, the one who I was quoting here, she got into, after her session, painting, scrapbooking, and drawing again, which is something that she hadn't been doing for years since the diagnosis. And it was something that she had done a lot when she was younger. And she seemed to be getting a lot out of that experience. So I think you're right that intuitively that seems like a really important direction to integrate, because art and music, those types of activities are things that are copacetic with the memory impairment. They're still able to participate and enjoy.
We have time for one or two more questions.
Okay, thanks. Yeah, I mean, Alzheimer's, of course, it makes me think of like neuroplasticity and maybe changes of cognitive impairment or slowing down the process. I was wondering if you have like physiological measures and what they are for neuroplasticity, let's say long-term potentials or whatever.
I'm not measuring those. There was a pretty neat paper from the Yale group, I think it was like a month ago, with their major depression patients who got psilocybin therapy using EEG and finding increased theta wave activity in the brain several weeks after psilocybin dosing. And that was also related to the antidepressant effects of the drug. And so theoretically, that may be a signal of some sort of neuroplasticity in the brain. Usually when you're looking at structural neuroplasticity in animals, it's much easier to do because you can open the brain up. But with humans, it's a little bit more difficult. And I'm not an expert in that area, but I'm sure there are markers we could be looking for. But again, these are very preliminary studies just to see, is it safe to give these people high-dose psilocybin?
The final question.
Really great talk. I just want to follow up on that first question that was asked. So for those individuals in the Alzheimer's trials that had no memory of the experience, I know that at UW-Madison, there's a recap trial that's actually trying to have individuals forget the acute experience, right? So have the amnesia. And Chuck can probably speak a little bit more on that. But I know the data is preliminary, but do you think that this provides perhaps evidence for the fact that that acute subjective experience might not be necessary for those behavioral effects that we so want to see, right? Those behavioral improvements.
I would say evidence is a strong word. So I don't think that this is evidence because it's 8 people so far. And even when we get data from the full, 20 person sample, I don't think we'll have evidence. But we have an interesting anecdotal observation, which is, and we may be able to look at this in terms of, because I started measuring how well do you remember the session afterwards. So if we can correlate that back to say, the people who were saying I remember it much more so, maybe showing more antidepressant effect, that will at least be a little bit more suggestive. But yeah, I mean, I think the implications are that because these people are not remembering, even though they seem to have a balance in their mood that looks good, and that's what their caregivers are observing, it may not be as long lasting. And so again, those are the reasons why I was thinking perhaps, if I was to do another study in this population, and if FDA cooperated, that we might be able to do like an at-home microdosing type study with, obviously supportive caregiver. But these are things to think about for the future.
Thank you very much for this interesting discussion and for the talk. Yeah.